Hello, my name is Christian. Thank you for letting me present some work we have done looking at dislocated hip hemiarthroplasty. Dislocation after hemiarthroplasty is a rare but serious event. These patients are frail, and the limited literature on the subject indicates significant morbidity following dislocation. Unfortunately, as a rare event, there's minimal evidence about how dislocations should be managed. In this study, we set out to explore our experience of dislocated hemiarthroplasties and compare it with others to identify trends for optimal management. We searched for hip hemiarthroplasty MUA over 16 years. Electronic records were then reviewed to identify patient, surgical, and implant factors. Using this method, over 16 years we found 35 dislocations, giving an incidence of 1.3%. Crude assessment shows these to be average hip fracture patients. The median time to dislocation was 25 days. 21 of 35 dislocations occurred within a month. Although the antilateral approach was associated with more dislocations, it should be noted that this is the favoured approach for the majority of hemiarthroplasty performed at our hospital. On the face of it, our results seem to confirm the old adage that having a high-volume junior surgeon perform your hemiarthroplasty may offer a better outcome. However, of course, we all know the consultants are left with the more complex ones. It is difficult to draw a conclusion with respect to implant type. Until recently, most of our hemiarthroplasties were Thompsons. This suggests modularity is no guarantee against dislocation. Confounding may occur with fitter patients potentially receiving a modular hip and a posterior approach. Of 35 dislocations, of which all received MUA, 29% remained stable. Here we have a variety of options depending on patient factors. Of those undergoing a second MUA, 13% were stable. Of the remaining 5 that went on to a third MUA, 40% remained stable. In the one patient who had a fourth MUA, the procedure failed and they went on to have a total hip replacement. Overall MUA success rate was 40%, but what about other procedures? Of the 2 open reductions, 1 was successful. Of the total cohort, 37% either had a girdle stone or were left dislocated. 8 patients underwent total hip replacement. 38% died within 3 months. 25% had recurrent instability. 25% developed deep infection. And 1 patient was alive at a year with good function. Our 30-day and 1-year mortality did not differ much from national trends for hip fracture. We acknowledge the significant limitations of our study. However, there remains a dearth of evidence in the literature concerning outcomes and management. Historically, a dislocated hemiarthroplasty was seen as a near-fatal event. Blewett and Mortimer's review of 1,000 patients from Nottingham reported an incidence of 2%, with a 6-month mortality of 65%. 12 years later, in a cohort of 643 patients, an incidence of 4.2% was noted, with a 6-month mortality of 30%. Both of these papers comment on the exceptionally poor prognosis if a second MUA is needed. Peterborough's Martin Parker noted a 1.4% incidence in a cohort of over 3,300 patients. In patients undergoing a first MUA, they report a 29% success rate. Both these figures are similar to our findings. However, while our overall MUA success rate was 40%, theirs was only 20%. Indeed, based on his unit's findings, Peterborough now recommend conversion to total hip following 1 failed MUA. Our results would urge caution, given only an eighth of our patients had good outcome over a year from their operation. Optimal management of the dislocated hemiarthroplasty remains unknown. Evidence is conflicting. We suggest a national audit undertaken via trainee collaborative to help inform best practice going forward. Any questions?